All right. Hello, everyone, and welcome to today's webinar titled New Challenges in Early Stage Cancer. I am Sydney McNeil of LabRoots, and I will be your moderator for today's event. Today's web seminar is brought to you by Diaceutics. To learn more, visit the Diaceutics booth in the exhibit hall and diaceutics.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the chat at the bottom of your screen and click send. We will answer as many questions as we have time for at the end of the presentation. I would now like to welcome our speaker, Professor Dr. Paul Hofman. Please visit the event website for a complete biography of our speaker. Professor Dr. Paul Hofman, you may now begin your presentation.
Thank you very much. Hello, everyone. Thank you very much for giving me the opportunity to present today the new opportunities, but also the new challenges for better detect and better treat early stage solid cancer, with mainly today a focus in lung cancer. Here is my disclosures. The agenda of this presentation, starting by a brief background concerning lung cancer by 2024 and the new challenges in this field of oncology. The epidemiology of lung cancer describes in this recent Nature Reviews paper showed that there is still, of course, and it's quite obvious this is the first cancer killer in the world, mainly due to tobacco-related exposures. However, something very important we need to take now into consideration the incidence of lung cancer in young population and in never smokers, representing today the fifth most common cause of cancer-related deaths worldwide. So with a higher incidence than those of colon and prostate cancers. The second highlight that I wish to mention is that even if surgery of early stage is the only option to get lung cancer cure, around half of early stage lung cancer patients will die from their cancer progression, from 45% to 75% according to the tumor stage. So more in details, you can see in this table and these graphs that the overall survival at 5 years after complete tumor resection varies from 96% to 47% in resected stage 3A. So considering these highlights, the question is how to better detect and how to better treat early stage lung cancer. And I think there is a small poll now for you. Maybe not, I don't know. Yes, so the question, in your laboratory, do you perform the early stage testing? So it's a very simple question. So the answer is yes or no. So now, I think for a better treatment and a better detection of early stage lung cancer, but in all solid tumors, there is probably a very important action of different stakeholders. And of course, these stakeholders have to be involved for an optimal care of these early stages. So of course, the oncologists to have the best treatment decision-making, but also the pathologist and the biologist to be able to use the best testing approach and to be able to give the results with a short turnaround time using the right samples, tissue and or liquid biopsy. And finally, something important, the politician and the pharma companies are to be involved in order to establish the right cost and the reimbursement procedures in all European countries. Therefore, the common goal of these stakeholders is to detect earlier and to treat better the early stage lung cancer. And one major development these last few years is certainly for that the use of liquid biopsy. So briefly, liquid biopsy is now very useful in late stage cancer and notably in late stage lung cancer for the detection of driver mutations and of different resistant mechanisms at tumor progression. And we know that there are different circulating components, and these components can be evaluated. But mainly right now, the main component is the circulating tumor DNA. And of course, now it's very important to develop different NGS approaches. But probably in the future, other components of interest may be analyzed, such as the CTCs, and why not the exosomes and the platelets. However, considering the early stage of lung cancer, the interest of liquid biopsy use is currently not well established, notably in daily practice. But this non-invasive tool can have different strong perspectives in the near future, and we will show some examples later in this presentation. I want also to highlight these results, and for this short introduction, I will say that it's noteworthy that even lung cancer is the first killer cancer. Lung cancer research, notably for early detection and treatment programs, should need an investment that matches the impact of this disease. As you can see here, lung cancer research receives disproportionately little funding comparatively to colon, breast, and prostatic cancers. So now what are the current recommendations concerning the early stage lung cancer patients taking care, but also the main issue in this setting? So this figure summarizes the different biomarkers to evaluate in order to have the best treatment decision making in early stage disease, meaning an adjuvant targeted therapy targeting the EGFR mutation versus a neoadjuvant treatment associated an immunotherapy and a chemotherapy. Therefore, it's mandatory today to look for the EGFR, the ALK, and the PD-L1 status in preoperative tissue biopsies. Of course, this can be made by one gene sequencing and immunohistochemistry, but also by NGS, knowing that other targeted therapy are coming soon in the near future in early stage, notably targeting the RET fusion. Moreover, it's now mandatory after neoadjuvant therapy to assess the impact of this treatment on tumor cells using histological two parameters, the complete pathological response defined by the absence of residual tumor cells in the surgically resected specimen, and what we call the major pathological response, which is defined by the presence of less than 10% of residual tumor cells in the resected specimen. So maybe now we can have the second small poll, if it's possible. So the poll is, what do you think are the top 3 biomarkers we look for in early stage non-small cell lung cancer? So I think we have to wait for the answer. Okay, let's keep going this presentation. Yeah, so great answer. Thank you. So this table summarizes some different biomarkers to evaluate, and I think it's very important to take care about this different possibility and the different issue and potential solution. Yes, so as you can see here, I think there is many issues concerning the sample quality and specifically before surgery, and because of the sample size, the percentage of tumor cells. And I think potential solution is certainly to have a very strong interaction between the oncologists, the pathologists, and the molecular biology. I think we need to work hand in hand. Also, it's very important to have a limitation of immunohistochemistry demands. And something very important is to increase the possibility to have enough nucleic acids by macrodissection for tumor area selection. Also, something very important is to have a good turnaround time for getting the report before surgery. And this is probably very important to have on-site analysis and to avoid to outsource the samples. And probably to have in the same location the surgical and the molecular pathology units, and to do not have two separate units. Also, probably something very important is to think about the cost and the reimbursement of the different molecular testing, knowing that usually NGS is costly. So definitively, it's very important to switch toward a reflex-sensitive NGS testing, but also to involve the politician duty and advocates input for the cost and the reimbursement. And finally, the integration of the different biomarker in early stage lung cancer, the PD-L1, immunohistochemistry, but also EGFR, ALK, and probably soon RET, is very important, meaning that we need for this integration to think about to have a unique pathological and molecular single report, to try to have a standardization, to have an optimal IT system, and of course to participate to different accreditation systems, and to have also an external quality assessment schemes. So what is now the dilemma and the different tools for detection of early stage lung cancer and early stage cancer in general? Of course, it's well known when we are working in thoracic oncology that we receive many samples in our labs. And in early stage, of course, we receive mainly small specimen, bronchial biopsy and transthoracic biopsy. Also a lot of cytological samples. So I think it's very important to consider the quality of these samples and mainly the percentage of tumor cells. Sometimes we receive some resected specimen, of course, after the bronchial biopsy assessment. And we can receive also blood samples, but I will give a few words about that a little bit later. So the main dilemma right now in thoracic molecular pathology is that we have an increased number of biomarkers to detect and to assess. But in parallel, we have a decreased tissue availability because we have more flexible endoscope, for example, to get the biopsy. So there is a balance between this increased number of biomarkers and the decreased tissue availability, meaning that sometimes we can think about to use liquid biopsy for this biomarker detection, but I will say that in early stage, the sensitivity and the specificity is not so high for the detection of circulating free DNA, and mainly early stage lung cancer do not shed circulating DNA. So I think right now using liquid biopsy is just for research program and also for the detection of the minimal residual disease, and we will talk about that a little bit later. So yes, there is advantages, of course, and limitation of using both liquid and tissue biopsy in lung cancer, but in early stage, it's very difficult to use a liquid biopsy since we have a lot of true negative results. However, as you can see here, liquid biopsy, it's well known, it's a non-invasive and repeatable tool. Of course, there is a lack of comorbidities, it's costly, but we cannot make right now the histological evaluation. There is no diagnosis of lung cancer using using a liquid biopsy. It's quite more difficult to mastering the pre-analytical phase comparatively to the standardization of the workflow in tissue. And there is a lack of sensitivity for different genomic alteration detection, specifically the fusion and the amplification. But I will say that in early stage, using liquid biopsy right now in daily practice is not possible. So there is many challenges in early stage lung cancer for using liquid biopsy. I think the two main objectives right now is to try to improve the use of liquid biopsy for the detection of cancer by different screening program in association with the CT scan. And also now there is many challenges for the detection of the minimal residual disease. Probably we need to outsource the samples in different platforms, but in routine clinical practice, it's very difficult to do that on site. As we know, and also for tissue biopsy and cytological samples, it's impossible to turn lead in gold, meaning that if we have a small amount of tumor cells and a low quality of nucleic acids, it's impossible to run a large panel of NGS. And we need definitively to control before doing the molecular testing, the quality and the quantity of the nucleic acid before doing NGS or even before doing, I would say, RT-PCR. And of course, there is different tools for the detection of a biomarker in early stage lung cancer. We know that in many laboratory immunohistochemistry for the detection of ALK is still ongoing for ROS1 also. We can also use a fish for the detection of ALK rearrangement, for example. And also we can use RT-PCR or digital PCR for the detection of the different EGFR mutation. But I will say that it's very important to try to switch to use systematically NGS in this early stage, because we can save tissue. It's possible to detect all the genomic alteration at the same time, not only, of course, EGFR, but also ALK rearrangement and ROS, but also soon RET. So I will say that behind EGFR, ALK, and ROS1, RET fusion will be very important to detect soon in early stage lung cancer. So I think NGS will be probably mandatory to do that, even in small biopsy. And of course, we need to take into consideration the cost and the reimbursement to do that systematically as a reflex testing without waiting the request of the physician. So coming back to the liquid biopsy, there is many programs for screening early stage, not only in lung, but also other solid tumors, colon, breast, prostate cancer. So Of course, the screening program using liquid biopsy is now developed in many institutions, but I will say in daily practice, it's not possible to do that. And now, of course, the challenge is also to try to detect the minimal residual disease after surgery in order to do an escalation of a de-escalation treatment in this patient. So when we want to use a liquid biopsy in early stage cancer, there is three different goals. First of all, the detection of early stage, then the detection of early recurrence after surgery, and finally, the goal can be also to try to have a predictive biomarker in high-risk population, for example, in lung cancer patient, in patients having a COPD, over 50 years old, heavy smokers. So there is different possibility to use liquid biopsy in early stage to better treat our patients. So first of all, the detection using liquid biopsy. There is many paper talking about the detection of early stage using a liquid biopsy. Of course, there is a new therapeutic algorithm for that. It's not so easy to use this different algorithm. And I would say that this multi-cancer test is developed mainly in program research, and I think it's quite difficult to use them in daily practice. But I think in the future it will be possible to use this different biomarker and to integrate also some artificial intelligence program in this field. I think there is different essays. I know that probably many institutions try to develop the fragmentomics approach, but also the methylation signature in the blood in order to detect different solid tumors before having late-stage tumors. So this evaluation of these different assays is mainly done from different institutions using the cell-free DNA approaches for this multi-cancer early detection. It's not so easy to develop this multi-cancer early detection test because we need to use a large panel and a whole genome methylation based approach in this paper was performed, and so it's quite cost is costly, and of course we need to consider that at the individual level is not so easy to have a very sensitive and specific test. So I think we need to wait a little bit before using these different tests in our hospitals. And also there is some limitation for developing this test to detect early stage cancer because sometimes there is false negative and false positive results, meaning that for the patients you can develop quite high anxiety. Of course, we need to consider the economic burden to develop this kind of blood sampling test. And I think it's not ready to develop this test in daily practice. However, there is many retrospective study and prospective clinical trials using these different tests. As you can see here, there is and I think it's not exhaustive, multi-cancer early detection using blood samples. So, of course, one well-known program was the GRAIL program, and at the last ESMO meeting, we have different results concerning the GRAIL program. But I will say that there is other also programs such as the Pathfinder program. And for example, here in this recent paper published in Lancet Oncology last October, There is results using this Pathfinder program, and the cancer was diagnosed from blood samples using this new assay in different solid tumors, early stage. And there is quite a good sensitivity and specificity, but we need to take care to do an inter-laboratory validation of this test and to do probably more prospective studies using this new test. Now concerning the minimal residual disease, I think it's a very exciting and promising topic in early stage. Of course, there is a different publication talking about the circulating tumor DNA performance to detect the minimal residual disease after surgery, and here specifically in non-small cell lung cancer. So this table shows that there is different sensitivity and specificity of the different tests. Here's the CAP-seq, the Signatera test, but also the CS-SMART and the MRD detect test. There is other tests such as the radar test recently presented at the last ASCO meeting. And as you can see here, the sensitivity and the specificity is very variable. So we need to take in consideration mainly the sensitivity of the test. And there is many issue when we are now developing this test in our laboratories. We know that it's very important because according to the detection of the circulating tumor DNA after surgery, it would be possible to have an escalation or a de-escalation of the treatment, meaning that if we keep going to have a circulating tumor DNA after adjuvant therapy, it will be possible to switch to a more aggressive therapy or to increase the dose of the treatment or to add a second treatment in combination. And conversely, if we have no circulating tumor DNA after surgery, it will be possible to have a de-escalation, meaning to switch to a less toxic therapy or to reduce the dose of the treatment. So according to the level of the circulating tumor DNA, it's possible to adapt the treatment. For this reason, we participate to this European project, the GUIDE MRD, led by Klaus Pantel in Hamburg. So in France, we take care about the MRD in lung cancer. This project was granted by the European Union, and the main goal is to do benchmarking of different tests after surgery to see what will be the best test and with the best sensitivity and specificity. However, I think there is many bottlenecks when we are talking about MRD in early stage cancer, not only lung cancer, but also colon cancer, prostate cancer, and breast cancer, for example. The first bottleneck, of course, is which assay for which tumors. What could be the cutoff for circulating tumor DNA level evaluation is not so obvious. How to assess clonal hematopoiesis when we are dealing with blood samples. When to get the blood samples? Is it just after surgery? Is it 12 weeks after surgery? 3 months after surgery? So the time point to get the sampling is not well established. And finally, what can be the turnaround time for getting the report? Because of course, depending of this turnaround time, it will be difficult or not to adapt the treatment. And at the end, of course, the cost and the reimbursement, because it's associated with the monitoring. So we will repeat this kind of test, and it could be a major issue in the future in terms of cost. So now the last point of these pillars is can we predict the onset of early stage solid tumors and here, for example, in lung cancer. So we did recently a test showing that in COPD patients, we can detect in the blood some circulating tumor cells using a new filtration assay. So it's possible to detect CTC in the blood even if there is no nodules in the CT scan, for example, in a high-risk population. So meaning that probably there is some sentinel circulating cells in the blood before the onset of the cancer using a CT scan. For example, in this patient, 1 year later, there is the onset of a lung cancer. It was an adenocarcinoma. And we repeat this test in several patients. And as you can see here, we can detect circulating tumor cells before the onset of CT scan images, meaning that it's possible to predict the onset of lung cancer. Of course, the major issue is the sensitivity of this test, so it's a very specific test. But in our hands, I think this test is not enough sensitive to be able to develop this test in daily practice. So now what we are doing in our institution, we develop a multimodal approach for this prediction, meaning that we integrate not only the blood samples, but also the imaging and some artificial intelligence program in collaboration with colleagues in the mathematics department. And also something very important in early stage cancer is to develop what we call an holistic approach. So we need to integrate clinical data, biomarker, but also imaging. And something very important is now to enter in the field of artificial intelligence for better treat and better detect early stage cancer. This is the reason why we decided to set up a new institute called Respirera in our city in order to better detect and better treat early stage lung cancer, but also other early stage solid tumors. Just to say that we are organize next year the International Symposium of Minimal Residual Cancer. And in this symposium, we have many talks talking about early detection of cancer and also about the minimal residual cancer detection with great speakers such as Charles Fanton, Fabrice André, but also the new president of the ACR, Lilian Sioux. So my last slide is probably when we are talking about early lung cancer and early stage cancer. I think there is a controversy, and I think it's quite difficult from my opinion to just say that now we name cancers and we need to do not call a lung cancer, but to call them an EGFR mutated cancer, meaning that probably we still have to talk about solid tumors, early solid tumors, and I think there is a balanced approach by integrating both solid tumor base and molecular classification at the same time. And I think it's quite difficult to quit the tumor classification, and we need to keep going to have a tumor classification based on organ origin, specifically in early stage. And with that, I want to thank you, and also, of course, I want to thank my team members working with me in Nice. And if you have any question, I can answer to this question. Thank you very much.
All right, wonderful. Thank you, Professor Dr. Paul Hofman, for your very informative presentation. We will now move into the live Q&A portion of the webinar. If you happen to have a question that you would like to ask, please do so now. You can simply put it in the chat located at the bottom of your screen, and we will answer as many of your questions as we have time for. Okay, it doesn't look like we have any questions in the chat just yet, so we'll give everybody a moment. Okay.
Yes, there is a first question. Why the ROS1 testing is not performed in the early stage of lung cancer? It's a great question. It's a great question. In my institution, we are doing this ROS1 testing. Now we switch from ROS immunohistochemistry and ROS1 FISH by doing systematically NGS for the detection of ROS fusion. So the first point is we're doing that systematically with ALK and RET, for example, using NGS, RNA NGS. And a lot of clinical trials, but it's not mandatory to have the ROS1 status, meaning that, for example, if you want to treat lung cancer with osimertinib as an adjuvant therapy, it's mandatory to look for, of course, the EGFR status, and also to be sure that you have an ALK wild-type tumor. So it's quite important. Yes, for me there is no evidence that if you have a ROS1 fusion, the osimertinib treatment will be not enough efficient. And I have no data on that, but for me it's always very curious to see that it's not mandatory to look for ROS1. And I asked this question to myself also, and it's a good question, but I have no answer for that. So another question is, and thank you very much. Another question, do you think that the whole genome could be the solution to resolve the main dilemma in thoracic molecular pathology? So I know that in some country, for example, in Germany, there is program now for whole genome sequencing. I think for me, it will be not the solution at least for tomorrow morning. Why? Because first of all, it's costly. Then probably the turnaround time to get the results is not so short. In early stage, probably we need to use a frozen specimen to be sure that we have the quality of the results. So, and we know that in daily practice, frozen biopsy is probably not the case for all the oncologists. It's quite impossible to have a frozen specimen systematically in daily practice. And I think for me, no, it will be not the solution. I think large panel is more than enough, meaning that panel with more than 300 genes is more than enough to detect all the different targets for molecular therapy. I think it's no, for me, whole genome is not the issue.
Perfect.
Yeah.
Sorry, go ahead, Dr. Hofman.
There is another question concerning what is for you the main obstacle to implement the MRD testing in all apps? The main. So if I can think about the main obstacle, it will be probably the cost and the reimbursement, because MRD means that we need to monitor the patient to repeat the test. And so if we repeat a test, it should be easy to use and not expensive. So this is the main obstacle. After, of course, in terms of technology, right now there is no stabilization of the assay. And probably the sensitivity and the specificity is something very important. We need to have ultra-sensitive assay. I know that now there is many assay in development. For example, the radar assay, and there is the results of the LoRa clinical trials presented at the last ASCO, showing that it's possible to follow the circulating tumor DNA in patients receiving osimertinib after surgery. And also something very important, I think that we need to develop on-site molecular testing and not systematically to outsource the molecular assay in commercially available platform. So yes, the main obstacle for me is the cost and the reimbursement, but of course the technology, and we need to be very sensitive and specific for that. There is another question regarding reference standards for circulating tumor DNA in early cancer. How will you address the different expression release of nucleic acid over the day of post-operative? Do we need to have different standards for every situation? So circulating tumor DNA in early stage, it's a challenge point, because, for example, we do not know if really we have circulating tumor DNA in stage 1, in stage 2, for example, and in lung cancer specifically. So the first point is to be sure that we have circulating tumor DNA and not only circulating germline DNA. So we need to see probably the methylation of the circulating free DNA and to see the index of methylation in this circulating free DNA. If we have methylation, it means that we have circulating tumor DNA and not only circulating germline DNA. So for me, it would be very important to combine a kind of test to be sure that we have a methylation. And this can be done before surgery and after surgery. Something very important also, probably beside circulating tumor DNA, we can look for other circulating components, exosomes, probably some protein biomarkers, and why not circulating tumor DNA. So probably by combining the different circulating components, we will increase the sensitivity and the specificity to detect early cancer. That's my point of view.
Wonderful. Thank you. It looks like that is all of the questions that we have received so far. So we will go ahead and wrap up with that last question there. Thank you again, Professor Dr. Paul Hofman, for your time today and for your very important research and your important focus on this specific area of precision medicine. We would also like to thank our sponsor, Diaceutics, for underwriting today's webcast. Before we go, I would also like to thank our audience for joining us today. And as a reminder, this webinar can be viewed on demand. We will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.
Thank you. Goodbye, everyone. Thank you so much.